This program has been approved for 1 AMA PRA Category 1 credit. Beginning with the 2016-2017 season, this webcast has also been approved for ABIM Maintenance of Certification, MOC points, through the partnership between the ACCME and the ABIM. To receive MOC points, a pretest must be taken prior to the start of the webcast. Log on to your OSU CCME account to access the test, which is located on the web page for this program. Following the webcast, you must also complete the post-test associated with the program. The following continuing medical education activity is the property of The Ohio State University. Duplication is prohibited by law. The Ohio State University is accredited by the Accreditation Council for Continuing Medical Education, also known as ACCME. OSU Center for Continuing Medical Education designates this CME activity for a maximum of 1 AMA PRA Category 1 credit. Each physician should claim only those credits that are actually spent on this CME activity. In keeping with the essential standards of the ACCME, Planning Committee members and participating faculty have been asked to disclose any relationship with commercial entities, discussion of commercial products, services, or unapproved off-label usage of commercial products or devices. Specific disclosure information can be obtained by contacting the Center for Continuing Medical Education at ccme.osu.edu. The information presented in this CME activity is meant for educational purposes only. Physicians' own judgment must remain central in the selection of the therapy options for their patients' specific medical conditions. The following is supported in part by the Ohio State University Wexner Medical Center and Arthur G. James Cancer Hospital and Solov Research Institute. Resistant hypertension. That's today's presentation with the following distinguished faculty from the Ohio State University Wexner Medical Center and Arthur G. James Cancer Hospital and Solov Research Institute. And now, our medical editor and moderator, Dr. Jim Allen.
In 1874, Nikolai Korotkov was born in Kursk, a town in western Russia. Well, he graduated from medical school at Moscow University in 1895 and then served in the Russian military in China during the Boxer Rebellion, where he was awarded the Order of St. Anna for his care of wounded and sick soldiers. Next, he went to Manchuria as a senior military surgeon during the Russo-Japanese War, where he became interested in vascular surgery after operating on a series of soldiers with arterial injuries. Now, many of these injuries would result in arteriovenous fistulas, and he could hear murmurs over these fistulas. He found that the murmurs went away if he occluded the arterial flow to the fistula using an inflatable cuff. Well, he wanted to find a way to predict the outcome of limbs after arterial surgery, so he started tinkering with his inflatable cuff. He returned to St. Petersburg in April 1905, and later in that year, at age 31, he made a presentation to the Imperial Military Medical Academy that changed medicine forever. His presentation was short, less than 1 page and only 281 words in total. He described using a cuff on the upper arm that was inflated and then slowly deflated. By listening with a children's stethoscope over the artery, he reported that he could hear short tones corresponding to the passage of the pulse wave under the cuff that represented the maximum arterial pressure, and then the tones disappeared at the moment of the minimal pressure within the artery. Shortly thereafter, Korotkov was deployed to Siberia, where he was a surgeon in a mining district, and he died there in 1820 of tuberculosis. Korotkov wasn't a physiologist trying to find a way to measure systolic and diastolic blood pressure. He was a surgeon trying to find a way to predict whether a wounded artery could be securely ligated when an amputation was likely. I don't think he ever envisioned the profound effect that he'd have on the practice of medicine. Well, currently throughout the world, every second somebody is having blood pressure measurements using the Korotkov sounds. By using those sounds, we know who to treat for hypertension and how they're responding to treatment. Most of the time, our treatment works. But sometimes, treatment's not successful, resulting in resistant hypertension. Today on MedNet, we're going to be discussing resistant hypertension. Here with me in the studio are hypertension experts from The Ohio State University. Dr. Christopher Chu is an assistant professor of internal medicine from the Division of General Internal Medicine, and Dr. Rima Kang is an assistant professor of internal medicine from the Division of Nephrology. Chris, Rima, welcome to the program.
Thank you, Jim.
Well, Chris, what's the target blood pressure that we should be shooting for most of our patients?
Now, there are lots of blood pressure guidelines out there, but in general, we shoot for less than 140/90 for our general population.
And Rima, what are the most common causes of resistant hypertension?
Thank you, Jim. Most commonly in our patients, we see obstructive sleep apnea, obesity as primary causes, but one must also take into consideration causes like renal artery stenosis and primary aldosteronism.
Well, thanks, Rima. Before we get started, let me remind you, you can send us your questions about resistant hypertension using the email feature at the bottom of this webpage. And now let's get started with today's program. Chris?
Thank you, Jim. So I want to first start off with a case, and I want our audience to think about this case as we go through our management for resistant hypertension. So here we have is a 56-year-old man with type 2 diabetes, and he's referred to clinic for blood pressure evaluation. He was diagnosed with hypertension 15 years ago, but still has persistent hypertension despite adherence to his medication regimen. His family history is significant for hypertension in multiple family members, most of whom were diagnosed between the ages of 40 and 50. The patient's home blood pressure readings were about 150/60 over 80/90. His medication regimen includes hydrochlorothiazide, 25 milligrams daily, valsartan, 160 milligrams daily, diltiazem, long-acting, 300 milligrams daily, clonidine, 0.2 milligrams BID, and metoprolol, long-acting, 100 milligrams daily. Our physical exam shows a blood pressure of 158/92 in both arms after 5 minutes of rest. The blood pressure did not change on standing. His heart and lung exams were normal, and there is no noted edema. His laboratory studies showed serum sodium of 138, serum potassium of 4.9, a chloride of 103, bicarb of 25, BUN 14, and a creatinine of 0.9. His urine dipstick was unremarkable. So to summarize, we have a middle-aged male with diabetes and hypertension. He is on a multiple drug regimen for his hypertension, but his blood pressure is still elevated. His physical exam and preliminary lab tests were pretty unremarkable. So what I'd like to do now is go through the objectives that Dr. King and I will go through on our discussion today. First, we're going to discuss about what resistant hypertension is. And for those patients who have resistant hypertension, identify those who might need a secondary workup. Once we have identified those patients, we should look at testing for measures for secondary hypertension, and in the end, learning about management for resistant hypertension and secondary hypertension. So let's first start talking about our definitions for resistant hypertension. Patients with resistant hypertension have blood pressure that remains above goal, despite use of 3 antihypertensives. In general, these 3 hypertensive medications are in different classes and are at their optimal doses. One of these medications probably should be a diuretic. In general, as discussed before with Jim, our goal blood pressure management usually is for less than 140/90. For some specific patient populations, like those with diabetes, established cardiovascular disease or cerebral vascular disease, and chronic kidney disease, we shoot for a blood pressure of less than 130/80. So to go back and look quickly at initial management of hypertension, I want to talk about a couple different guidelines that we have. Probably our most common guideline is JNC8. As you can see in this algorithm here, JNC8 actually has slightly different goals for blood pressure management. In this guideline, it shows that they tend to be a little more conservative in management. In general, it shows that goal management in JNC8 is for blood pressures less than 140/90, except for patients who are greater than 60 years of age and do not have CKD or diabetes. Using the JNC8 algorithm, you can see the flow chart here in terms of how medications are added. This is a little outside the scope of our discussion today, but in general, the strategy for this flowchart is a couple different ways. So the first strategy JNC8 recommends is either starting with one drug, titrating it to maximum dose, then adding a second drug. A second strategy would be to start one drug, and then if needed, add a second drug before achieving maximum dose of the first drug. Or a third strategy is to begin with 2 drugs at the same time. JNC8 does recommend a couple medications for your initial choice of blood pressure management. The first would be either an ACE inhibitor or an ARB, a thiazide diuretic, or a calcium channel blocker. Now that we've discussed a little bit about initial management of hypertension, I want to give it to Dr. Rima Kang to discuss what is resistant hypertension in terms of prevalence and why we care about management.
Thank you, Chris. So we'll start off by talking about the prevalence of resistant hypertension. It's actually relatively unknown and highly variable. Some studies report a prevalence between 2 and 40%. According to NHANES, the prevalence was reported to be 11.8%. According to ALLHAT, the prevalence was 12.7%. In the CRIC study that looked at patients with renal insufficiency, there was an estimated prevalence of 40% in hypertensive patients with chronic kidney disease. Part of the variation in what accounted for the fact that there's such a discrepancy in the prevalence of resistant hypertension is the fact that these studies did not report consistent medication dosing, whether the patients were adherent to their medications or if they were on a diuretic. So overall, we need to have a consistent definition for resistant hypertension to be able to limit this variability. The graph here illustrates the prevalence of apparent treatment-resistant hypertension by eGFR. In a study done on the patient population used in the CRIC study, there was a 14% higher risk of apparent treatment-resistant hypertension in patients who had a drop of GFR by at least 5 milliliters per minute. And as you can see here, as the GFR drops to below 30, the prevalence increases by a large margin. Some of the risk factors for resistant hypertension include older age, male sex, African Americans, patients with proteinuria, and going hand in hand with that are patients with chronic kidney disease, defined as serum creatinine greater than or equal to 1.5 milligrams per deciliter. Other individuals include those with diabetes or those with higher BMI. So let's discuss why is control of resistant hypertension important. VA studies have shown that reduction by 96% in cardiovascular events in patients who actually had optimal blood pressure control. The ALLHAT trial showed that patients who had a higher risk of coronary artery disease, stroke, all-cause mortality, heart failure, peripheral arterial disease, and ESRD if they did not have controlled blood pressure. In the CRIC study, patients with CKD had 38% higher risk of cardiovascular events or all-cause mortality and 28% higher risk of ESRD. There was also a 50% decline in GFR noted in these patients. In order to look at a patient with resistant hypertension in the outpatient setting, we must go through several steps: confirming treatment resistance, excluding pseudo-resistance, identifying lifestyle and reversing lifestyle factors, discontinuing interfering substances, screening for secondary hypertension, pharmacologic treatment, and ultimately referral to a specialist if indicated. I'll pass it on to Chris to start off discussing our patient.
Thank you, Rima. So step number one, as discussed, is to confirm treatment resistance. So as we discussed in earlier for our definitions, treatment resistance is seen in patients who are already on 3 medications at least. So it is important to make sure that these patients are actually taking their medications. I know this can be difficult in the outpatient setting, but it has been studied. In this study by Jung et al., they studied a population of patients with resistant hypertension. In this patient population, they were more than 50% were found to be either partially adherent or non-adherent to the medications. So definitely it is out there when patients are not taking their medications. It's understandable this can't be done that easily in the outpatient setting, but an outpatient provider should at least assess barriers for adherence. These would include making sure the patient can pay for the medications, ensuring that the medications you prescribe are on a patient's formulary for the insurance, or even checking make sure that they have a pill reminder or a weekly pill box to help them remember their medications. Once assessing for adherence to medications, our next step would be to look at pseudoresistance. So what does pseudoresistance mean? So these are patients who take their medications, but their blood pressure readings still continue to be high, but they may be falsely high. Probably the most common thing to look at is to look at blood pressure technique. So the first thing you should pay attention to is the size of the cuff. A small blood pressure cuff can result in falsely high blood pressure readings. One should remember that blood pressure should encircle the patient's arm circumference at least 80%. Another couple factors to look at for blood pressure technique would be patient positioning as well as timing for their blood pressure checks. So a patient should be at least resting for 5 minutes before they get their blood pressure checked. I can understand this is difficult even in my own outpatient clinic. Very often my patients come in, they sit down in the waiting room, and as soon as they sit down, they're whisked away to my exam room and their blood pressure cuff is checked right away. Very often I have my patients sit for a little while I gather a little more history, and then I check their blood pressure again. Other things to keep in mind is positioning for a blood pressure reading when the patient's blood pressure is being checked. Patient should be sitting with their back supported, their legs uncrossed, as well as when the arm that is the blood pressure being checked should be elevated to the level of the heart and supported. The reason for this is several studies have shown that if the back is unsupported, it can increase your blood pressure by 6 points. If your legs are crossed, it can increase your blood pressure by 2 to 8 points. And crossed legs can actually increase your blood pressure by 10 to 12 points. Another thing to do is to make sure that the patient's blood pressure cuff at home is appropriate. Very generally, often I have a patient come in with their home blood pressure readings and they're elevated. If they have their blood pressure cuff with them, I have them demonstrate that they're using it appropriately, that they're in the appropriate position, and then after they check their blood pressure, that their readings correlate to the blood pressure readings we have in clinic. Another thing that we have to think about in terms of pseudoresistance is white coat hypertension. The prevalence of white coat hypertension is about 20 to 30%. For these patients, I try to do 24-hour ambulatory blood pressure monitoring. A 24-hour blood pressure monitor is pretty much a device that a patient wears for 24 hours. It checks their blood pressure about every 15 to 20 minutes during daytime hours and every 30 to 60 minutes at nighttime hours. What we get from the results of a blood pressure monitor like this is we get a couple different things. First would be an average of the 24-hour blood pressures. In general, we look for a blood pressure of less than 130 over 80, and so if it's elevated from that, then they probably have hypertension. You will also get two other readings from your 24-hour ambulatory blood pressure monitor. That would be your daytime or wakeful readings and nighttime readings. Your daytime readings generally tend to be less than 135 over 85 if they're well controlled, and less than 120 over 70 at nighttime if they're well controlled. This difference in blood pressure at nighttime is called nighttime dipping. Non-dippers is something to be aware of, but is outside the scope of our talk today. So let's go back to our case and apply the principles we learned. So our patient shows his technique with his home blood pressure cuff, and it seems to be appropriate. He waits an appropriate amount of time and is in the appropriate position. His blood pressure readings are consistent with our office reading. We look at our home cuff as well as our office cuff, and they seem to be appropriate size, and our measurements seem appropriate. We talk to him about his medication use. He reports no irregularities. He says that he uses a pill box and it helps remind him all the time. So now that we've assessed for treatment resistance and pseudo-resistance as well as adherence factors, we should look at modifiable risk factors, including lifestyle factors that we may be able to help the patient with. One thing to know about obesity-related hypertension is it's complex and is not fully elucidated in the literature. Things that can cause hypertension and obesity include impaired sodium excretion, sympathetic nervous system activation, as well as activation of the renin-angiotensin-aldosterone system. One study has shown that a weight loss of 8 kilograms can result in a drop of 6 to 10 points. Another thing to look at is dietary sodium intake. So there are some patients that are salt sensitive and some that aren't. In particular, salt-sensitive patients such as elderly patients, African Americans, and patients with CKD. Another study has shown that a low-salt diet can decrease the blood pressure by 23 over 9 points. One last lifestyle factor I'd like to discuss today is about alcohol use. Those with heavy drinking can obviously have elevated blood pressure. One study has shown that abstinence of heavy drinking can result in a drop of about 7 millimeters of mercury. After looking at lifestyle factors, one should look at other factors that could be influence a patient's blood pressure. Most oftentimes, these are over-the-counter medications, which are not as well discussed with providers often because patients forget that they're taking these medicines. Probably the most common medication would be NSAIDs, or non-steroidal anti-inflammatory medications. These medications can blunt the effect of ACE inhibitors, angiotensin receptor blockers, and beta blockers. They've also been known to cause fluid retention. One meta-analysis has shown that use of NSAIDs can increase your mean arterial pressure by about 5 points. Another medication that I don't have listed here is actually steroids, like prednisone. This can also cause fluid retention and increase blood pressure. Another common over-the-counter medication would include decongestants like Sudafed or pseudoephedrine, diet pills, cocaine, alcohol as discussed before, oral contraceptives, cyclosporin, erythropoietin, natural licorice, and even herbal compounds like ephedra and mahong. So let's go back and apply these principles to our case again. So our patient, after evaluation, is noted to have a BMI of 30. We discussed lifestyle modifications, including dietary changes and exercise. He says he generally does not add salt to his diet, but will refrain from now on. He also does not eat out, so he doesn't have to worry about other people adding salt to his diet. He does not drink any alcohol because it exacerbates his heartburn. When we review his medications, he does say, oh, I do take an NSAID, and he says he takes ibuprofen occasionally for his arthritis. On further discussion, he says he really only takes it 1 to 2 times per month. So I'm going to give back to Dr. Kang to discuss what are the reasons for secondary hypertension, like with this case.
Thank you, Chris. Moving on to screening for secondary hypertension, the more common causes are listed to the left and the uncommon causes to the right. The common causes can actually be screened for in the primary care office before referral to a specialist, but more often than not, either one can screen for these processes. Common causes include obstructive sleep apnea, obesity, renal parenchymal disease, which can easily be evaluated by checking spot protein creatinine ratio or albuminuria, or by a simple blood test for serum creatinine. Primary aldosteronism, and renal artery stenosis. On the right, with the uncommon causes, these are causes that should be kept in the back of your mind, but ultimately will most likely be worked up by a specialist. We will discuss pheochromocytoma and Cushing's disease as some of the uncommon causes. Renal parenchymal disease. Achievement of goal blood pressure in the CKD population was uncommon according to NHANES. Despite the use of 3 different antihypertensives, less than 15% of patients followed a nephrology clinic were controlled to less than 130/80, which, remember, is our goal for the CKD population in general. What accounts for the treatment resistance is likely increased sodium and fluid retention in CKD patients. There are special considerations for using diuretics in patients with impaired GFR. Renal artery stenosis is a fairly common cause. It's a manifestation of systemic atherosclerosis. Oftentimes, it is associated with coronary, cerebrovascular, peripheral vascular, and aortic disease. The prevalence is now actually increasing, but this could be due to improved screening techniques, and additionally, individuals are now surviving long enough to develop critical atherosclerosis in the abdominal vessels, and eventually leading to renovascular hypertension. Renovascular hypertension can lead to renal insufficiency and ESRD. Generally, the progression is slow, roughly about 8 to 9 years. In patients with renal insufficiency, coronary artery disease, or vascular disease, smokers, those with abdominal bruits, stenotic lesions are typically bilateral in 20 to 40% of these cases. These patients are also likely to be non-dippers. Their blood pressure does not dip at night, and this actually portends a poor prognosis in the long term. They tend to have severe end organ damage and left ventricular hypertrophy. The last point mentions that bilateral renal artery stenosis should be suspected in the presence of flash pulmonary edema. This can develop because of impaired natriuresis. Additionally, it can develop because the left ventricle loses contractile strength in the setting of increased afterload. Mortality in these patients is usually caused by cardiovascular events. The diagnosis of renovascular hypertension. It usually requires a stenotic vascular lesion and activation of the RAS system. The imaging options include duplex ultrasound, captopril renography, MRA, or CTA. One must take into consideration the positives and negatives towards using each study. The duplex ultrasound is a good measurement of flow velocity. This measures acceleration of blood flow through the stenotic lesion, and anything over 60% indicates a positive test or a stenotic lesion. This is a relatively inexpensive test and easy to do. It, however, does not give good functional information. Additionally, a resistive index greater than 80% on a duplex ultrasound is a strong negative predictive value for this test. Captopril renography can also be utilized. It is good to estimate renal perfusion. A change in GFR can help determine the reversibility of the lesion. This modality is often underutilized. The last two include MRA or CTA. MRA and CTA should be taken into consideration in the chronic kidney disease population. Gadolinium used with the MRA carries a high risk for nephrogenic systemic fibrosis, whereas administration of contrast for a CTA can also lead to contrast-induced nephropathy. Treatment of renal artery stenosis includes conventional RAS blockade, the ACE inhibitors, renin inhibitors, and ARBs. Other medications that interfere with RAS include dihydropyridine calcium channel blockers and diuretics. Typically, angiotensin II in a normal individual maintains GFR by efferent arteriolar vasoconstriction. So the caveat to adding RAS blockade is that it can cause AKI due to a drop in filtration pressure because of the fact that you're taking away that efferent arteriolar vasoconstriction. The drop in GFR with the addition of RAS blockade is more apparent in the setting of bilateral renal artery stenosis or those with a solitary kidney. Adding RAS blockade is something to take into consideration in any individual who decides to do so. However, a 30% increase in the serum creatinine should cause one to think to stop the therapy. Revascularization offers a permanent cure in fibromuscular dysplasia. This should also be considered in patients with bilateral disease, high-grade stenosis, or progressive worsening of renal function. It can also be considered in individuals who have uncontrolled blood pressure, even despite optimal medical therapy. However, the data on this is still not quite conclusive. The CORAL study noted that there was no improvement in mortality, cardiovascular, or renal events in patients who were treated on optimal medical therapy versus revascularization. It is also important to note that despite revascularization, blood flow through the stenotic despite low blood flow in the presence of a stenotic lesions, without revascularization, most patients are able to maintain renal tissue oxygenation. So it is unclear whether or not revascularization is of benefit. Over the long term, this can lead to decline in renal function, glomerulosclerosis, tubular interstitial fibrosis, and cortical scarring. But remember, the progression of this is relatively slow. Moving on to the diagnosis of primary aldosteronism. This is common in patients with resistant hypertension with a prevalence of about 20%. Theoretically, in these patients, the serum potassium should be low with metabolic alkalosis. However, this is actually quite uncommonly seen and actually may be a late presentation of the disorder. There is an unclear stimulus for aldosterone excess, but it may be linked to obesity. An aldosterone level of greater than 15 nanograms per deciliter can cause you to think of primary hyperaldosteronism. I will mention that adding mineralocorticoid receptor blockade for any level above 10 is reasonable to do. Aldosterone-renin ratio of 25 to 50 generally confirms primary aldosteronism, but requires additional testing. Greater than 50 would actually be more suggestive. If the ratio is 25 to 50, confirmatory testing is required. We will talk about the first two, the first being oral sodium chloride loading. The dose is 200 millimoles per day for 3 days, and then a 24-hour urine collection is obtained for urinary aldosterone. If the level is above 12 micrograms per day, then the diagnosis is confirmed. The next test is the saline infusion test. In the morning, one must measure aldosterone, renin, cortisol, and potassium. The patient then receives a 4-hour infusion of 2 liters normal saline through the IV. At the end of the test, the aldosterone level is measured. An aldosterone level greater than 10 nanograms per deciliter at the end of the test confirms the diagnosis. Once we know that our patient has primary aldosteronism, we proceed with getting a CT scan. If an adenoma is identified, we obtain adrenal vein sampling to determine the functionality or lateralization. If there is a functional adenoma, one can be referred for surgery versus otherwise treating with medical therapy with mineralocorticoid receptor blockade. It is important to note the medications that interfere with the diagnosis of primary aldosteronism. Most patients that have the workup for primary aldosteronism may meet the definition for treatment-resistant hypertension, so certainly it will be difficult to stop some of these medications when testing our patients. Furthermore, elevated blood pressure and potentially a component of sodium or volume excess inhibit renin in most patients. Beta blockers in particular inhibit renin, but this generally does not confound the diagnosis. ACEs and ARBs inhibit renin along with the diuretics. The aldosterone receptor blockers, such as spironolactone and eplerenone, will increase the renin and aldo levels. These are the only medications that absolutely must be held to pursue testing. They must be held for at least 6 weeks. The next cause is obstructive sleep apnea. This is common in patients with resistant hypertension. It's more common and more severe in males. The mechanism is not perfectly understood, but likely involves upper airway resistance, leading to increased sympathetic nervous system activity. Increased sympathetic nervous system activity increases cardiac output, peripheral resistance, and increases your fluid retention. Patients with ESRD are susceptible to volume overload, which can contribute to hypertension and obstructive sleep apnea. Next, we'll talk about pheochromocytoma. This is relatively rare, 0.1 to 0.6% of patients with hypertension. Despite this, there are many cases that are missed. In some autopsy studies, 75% of cases were ones that were not suspected in the first place. Blood pressure can be variable depending on norepinephrine secretion by the tumor. Blood pressure variability is an independent risk factor for cardiovascular morbidity and mortality. Diagnosis involves the following constellation of symptoms: headache, palpitations, sweating, and episodic hypertension. To screen for pheochromocytoma, we check plasma-free metanephrines. There are several medications that can also interfere with this diagnosis, including TCAs, phenoxybenzamine, labetalol, MAOIs, sympathomimetics, caffeine, levodopa, carbidopa, cocaine, acetaminophen, and buspirone. Next, we'll talk about Cushing's syndrome. To differentiate between Cushing's disease, which is ACTH release from the pituitary, Cushing's syndrome is any syndrome that has cortisol excess. Cortisol stimulates the mineralocorticoid receptor, leading to hypertension. Cortisol excess can be from an adrenal adenoma or carcinoma. Rarely it is from ectopic ACTH, or most typically in our patient population, we'll see patients who are on steroids, which can lead to the classic Cushing's syndrome. End organ damage is typically more severe in Cushing's syndrome. And cardiovascular risk is high because the condition is associated with diabetes, metabolic syndrome, sleep apnea, obesity, and dyslipidemia. The diagnosis of Cushing's syndrome involves checking an elevated or finding an elevated free cortisol level. A dexamethasone suppression test can also be obtained. 1 milligram is administered at midnight. If the 8 a.m. plasma cortisol level is not suppressed, this helps confirm the diagnosis. A high-dose dexamethasone suppression test is enough to suppress ACTH released by the pituitary, but not enough to suppress ACTH that would be released in the setting of ectopic ACTH. Imaging includes CT and MRI of the pituitary or adrenals. Treatment is adrenalectomy if an adenoma is confirmed, or tumor removal if there is ectopic ACTH. And now I'll hand it over back to my colleague, Chris.
Thank you, Rima. So, thinking of everything that Rima has talked to us recently, we go back to our case. We go back and ask more history from our patient and try to see if there are other reasons for secondary hypertension in our patient. So, as mentioned previously, patient has an elevated BMI. As we probe further in history taking, patient tells us that his wife says that he snores very loudly and is fearful that he stops breathing sometimes when he's sleeping. He endorses non-restorative sleep, and he feels very tired every morning despite saying that he gets 8 hours consistently. Patient is sent for a sleep study and is diagnosed with obstructive sleep apnea. He is started on a CPAP. He then follows back up in clinic and is found to have improved blood pressure control, but still not at goal. So with our patient, we've looked for possible secondary causes of hypertension. The next step is to optimize their pharmacologic therapy. So here on my slide, actually, probably the bottom bullet point should be first is make sure ultimately therapy needs to be tailored to the patient's medical history. That includes diabetes, heart disease, or CKD. As we've discussed, resistant hypertension needs to be in patients who are already on 3 medicines, preferably with one of them being a diuretic. Diuretic really is the cornerstone of good blood pressure management. If a patient is not on a diuretic, they should be started on one. If they're already on a diuretic like hydrochlorothiazide, one could consider switching them to chlorthalidone, as is considered to be more efficacious and stronger. One thing that providers need to be aware of is that chlorthalidone is much stronger and therefore has higher blood pressure management, but they can also have increased risk for electrolyte abnormalities. These patients should be checked routinely to make sure that their electrolytes are not abnormal. One thing to keep in mind is for our patients with CKD, hydrochlorothiazide and chlorthalidone may not be as effective. In our patients with GFRs down to 25 to 30, one should consider switching to a loop diuretic as it may be more efficacious. One group of agents that are not as used for blood pressure as I think they should be are aldosterone antagonists, as they can be quite effective. Aldosterone antagonists can be used irrespective of plasma aldosterone levels, plasma renin activity, and aldosterone renin ratios. One study by Nizikala et al. Had a group of patients who were all on 4 medications for blood pressure control. All these medications were at least on a diuretic and an ACE or an ARB. This study showed that patients who were started on spironolactone on average had a lowering of 25 points over 12 points. So keep in mind that spironolactone or eplerenone can be very useful in these patients. So let's go back and apply these principles to our case. So we have our patient, we reviewed his medications and noticed that he was on hydrochlorothiazide. We switched him to chlorthalidone and his chemistries were monitored closely. After initiation, they remained stable and he was continued on them. In fact, his blood pressure improved to such an extent that his clonidine was weaned off. Patients still followed in clinic. A few years go by, and his blood pressure seems to creep up again. As we monitor his serum creatinine, it seems to also creep up as well. He now qualifies for stage 4 chronic kidney disease. This is a patient that in my clinic I would send to nephrology for referral. So I'm going to hand it back to Rima here to tell me what she's going to do for him.
Thank you, Chris. Hypertension is something to certainly address in the patient population that I see, but there are in particular guidelines that must be addressed to the CKD population. In patients with CKD, regardless of race or diabetes, the initial or add-on treatment should include an ACE inhibitor or an ARB. KDIGO recommends a goal blood pressure less than or equal to 140/90 in those without albuminuria and less than or equal to 130/80 in those with micro or macroalbuminuria. We must work to optimize volume status and ensure that patients are on RAS inhibition. As mentioned previously, all CKD patients should be on RAS inhibition unless there is another contraindication. If they're advanced CKD or if they have issues with persistent hyperkalemia, those are other things to consider. The patient's dietary sodium intake can be measured by a 24-hour urine collection for sodium excretion. Oftentimes, I can see patients and discuss this with them. There's a common misconception. Patients think that they're on low sodium diet, but this can be disproven or proven based on their 24-hour urine collection. Sleep apnea, as we mentioned previously, is very common in this population, mainly because fluid overload can contribute to swelling of the hypopharynx, the palate, and the nasal cavities. In patients with stable CKD, renal angioplasty or stenting is not of benefit. Routine screening for atherosclerotic disease, renal disease, is not recommended. However, if rapid worsening of their GFR or uncontrolled hypertension, this can still be a consideration. KDIGO guidelines recommend sodium intake of 2 grams per day for those not on dialysis. One special consideration is that the DASH diet actually confers an increased risk for hyperkalemia, especially in those individuals on RAS inhibition. Getting back to our case, once the patient was referred to me, he was switched from chlorthalidone to Lasix BID and started on spironolactone. His blood pressure became well controlled. He will continue to follow up with nephrology every 3 to 4 months.
Rima, there's a lot of really important information that you and Chris have discussed today. So let's go over how you would use a lot of these recommendations in a few hypothetical cases. And the first case is a 55-year-old man who you're seeing for the first time, and he's referred in for resistant hypertension. And in the office, his blood pressure is 155/96, and he has no other medical illnesses. His chemistry panel's normal, and he tells you that he's taken amlodipine 10 milligrams a day, hydralazine 50 milligrams 4 times a day, and atenolol 50 milligrams a day. How would you approach him?
Thank you, Jim. This patient actually does not meet the definition for resistant hypertension. Remember that he should be on 3 medications, all at optimal doses, one of which should be a diuretic. Hydralazine is one of the last line therapies I would actually start. So in this individual, I would stop the hydralazine and substitute a diuretic. Whether that's hydrochlorothiazide or chlorthalidone with his normal GFR, either one is okay.
A little bit later this season, we're going to be discussing more basic approach to simple hypertension, and we'll cover medication selection, but I did want to get your take on a couple things. For your initial diuretic of choice, what's your preference?
In a patient with normal GFR, I usually start off with hydrochlorothiazide.
And then for a vasodilator of choice, what do you like?
Typically if they're on a calcium channel blocker, if they're on a diuretic, and then a beta blocker, after that I would consider, in most patients, they're going to have aldosterone excess. So 4th line, I would actually start mineralocorticoid receptor blockers. Past that point, I suppose I would start with clonidine.
And for patients who are just using an ACE inhibitor for hypertension, do you see much difference between ACE inhibitors and ARBs?
Not generally, no.
Chris, let's go to the second case. And this is a 60-year-old woman who's got arthritis, and she's taking hydrochlorothiazide 25 milligrams a day, lisinopril 50 milligrams a day, and amlodipine 10 milligrams a day. She also has stable diabetes that's managed with metformin, but she doesn't take any other prescription medications. Her blood pressure has been very well controlled for years, but in the office today, it's 160 over 100. So you ever come back a week later, it's still 160 over 100. She's not taking any new prescription medications, and her only subjective complaint is that her arthritis has been a lot worse recently. How do you approach her?
That's a very good question, Jim. So this is one patient that history is key. So you need to ask her specifically, are there other medications that she takes over the counter besides the ones that she's prescribed? Especially if her arthritis is one of her concerns, she is most definitely taking a medication like an NSAID in this case. I would ask her specifically, are you taking anything like ibuprofen, naproxen for your pain? For her, I would assess to make sure that would be the main culprit for elevated blood pressure. And then I would see if there are other things we can do for her pain. Things like topical medicines or possibly other interventions, or even just changing a medication like Tylenol, which has no blood pressure effect.
Well, in the course of the program today, we talked about lifestyle changes as being integral when you're approaching patients with resistant hypertension. Can you go over some of the common lifestyle recommendations that you make?
So with initiation of blood pressure medications, especially if you follow JNC8 guidelines, lifestyle recommendations go hand in hand with this. So this includes smoking cessation, control of blood glucose and lipids, diet control, as we discussed before. Something like the DASH diet has a lot of discussion about sodium reduction as well. Alcohol consumption, as discussed during the resistant hypertension discussion, is important as well. Those with heavy alcohol intake definitely should decrease, and that might help their blood pressure as well. Physical activity, obviously weight loss, as we discussed with obesity, can have a major impact on blood pressure as well.
All right, true confessions. I'm a pulmonologist, so I don't know what the DASH diet is. What do you tell your patients when you're recommending a DASH diet?
So the DASH diet is actually very hard to I think, accomplish. Generally, I actually have handouts in clinic, and when I do recommend a DASH diet, I have my nurse come in, or I refer a patient, if they want to a nutritionist to discuss it more thoroughly. In general, it is a variety of, honestly, just healthy foods that people can use to help them, and it's been shown to actually have some blood pressure reduction.
All right, Raymond, let's go with the next case. This is a 50-year-old man, and he's had hypertension for the past 5 years. Mm-hmm. He's on 25 milligrams a day of hydrochlorothiazide, 20 milligrams a day of lisinopril, and 0.2 milligrams twice a day of clonidine. And despite that, her blood pressure is still high, 156 over 96. Her chemistry panel shows a potassium of 3.0 and a serum CO2 of 34. What should we be thinking about?
Jim, this looks like a classic case of primary aldosteronism. As we mentioned previously, these cases don't always present with hypokalemia and metabolic alkalosis, and in fact can be a late manifestation of the disease process. But certainly that's the direction I would head in next by checking her renin and aldosterone levels. If the ratio is within that 25 to 50 range, then we'll proceed with confirmatory testing with either the oral salt loading test or the saline suppression test, and from there, the CT and adrenal vein sampling.
You had mentioned the captopril renography. What is that?
Captopril renography is not a test that's generally utilized very much, but in general it shows the renal perfusion. It actually provides a picture so that you can see how much the stenosis is actually contributing to perfusion in the kidney.
Well, Chris, the next patient's a 45-year-old woman who's taking chlorothalidone, metoprolol, and benzapril, but her blood pressure is still about 160 over 100, and she has fatigue and headaches, mainly in the morning. Her BMI is 42. How would you approach her?
Well, this one was actually very similar to the patient we presented in our discussion today. With her morning headaches, fatigue, and her elevated BMI, I would definitely be worried about secondary hypertension, including obstructive sleep apnea. She is one that I would definitely send for a sleep study to be diagnosed with sleep apnea and possibly be started on a CPAP or BiPAP.
Now, obesity is really common in the American population, and you had mentioned that obesity can be one of the factors that can contribute to resistant hypertension. Is there a particular medication regimen that tends to work better in obese patients?
I don't feel that there is one in particular. In general, in terms of starting medications, I would stay with the guideline like JNC8. Go along the recommendations. Start with a medicine, usually a diuretic, unless they have other medical problems. If they have CKD or diabetes, maybe an ACE inhibitor or an ARB.
And then, of course, I guess the other good thing about obese patients is you do have a few things you can work with in terms of weight loss and identification of sleep apnea that might contribute to improved blood pressure management.
Correct.
Well, Rima, the next case is a 25-year-old man with hypertension since he was a teenager. And he has no other medical problems. His BMI is okay at 23. He drinks alcohol rarely, and he doesn't use any street drugs or over-the-counter medications. And you've tried several different antihypertensive regimens over the past 6 months, but nothing seems to be working. What should we be thinking about in this guy?
Jim, this is an interesting case. It's a young gentleman with resistant hypertension. Certainly we should be thinking about those uncommon causes. In this patient, the most common thing that I would think of is aortic coarctation. So we would check for blood pressure in both arms, both legs, and check for the femoral pulses, and then proceed with further testing, EKG, echocardiogram, and most importantly, the chest x-ray to confirm rib notching. And from there, we can get further imaging, the CT scan, to determine where the coarctation is. If they need better blood pressure control, then we can refer for either stenting or balloon angioplasty to see if that improves the blood pressure control.
One of the tests that you all had alluded to over the course of today's discussion is the 24-hour blood pressure monitor. And I've never really known in my own practice when I should be using that test. When do you recommend we order a 24-hour blood pressure monitor?
I generally order it to confirm white coat hypertension. So if a patient comes to the office and they're always elevated in the office and they report good blood pressure control at home, that's when I order it. I know in general there are, in some of the primary care offices, you're able to do the ambulatory blood pressure monitoring, but in our office I actually order the test. It provides a nice printout so that we can see what the average blood pressures are.
Well, Chris, the next patient's a 75-year-old woman with hypertension, and you've been adding more and more drugs to her regimen to the point that she's now on furosemide, amlodipine, and atenolol. You get a chemistry panel, and her creatinine is only 1.2, but her calculated GFR on the blood test result reads out at 30. What do you think's going on with her?
Well, so one thing to realize with this patient, Jim, is that even though her creatinine is 1.2, she's also 75 years old. She's not like a strapping young guy. So that means her GFR is probably going to be around 30. This patient, especially with her low GFR and elevated high blood pressure, she definitely has some sort of CKD, renal parenchymal disease, which, well, then she'll have high blood pressure with that. For her, I would suggest, since she's already on 3 medications, including a loop diuretic, which would be reasonable in a patient with low GFR, is I would start spironolactone on her, and I think she would probably get a pretty good response with that. Now, the thing to recognize with a 75-year-old is that, especially we go with JNC8 recommendations, one could consider, because she's over 60, shooting for a blood pressure of, relaxed to maybe 140 over 90. With her CKD, Rima might consider going down to 130 or over 80, but you should keep in mind, what are her risks for falls, other issues that she might have.
Well, Rima, let's go with the last case. And this is a 68-year-old smoker with difficult to control hypertension. He has a history of myocardial infarction and previous TIAs that had led to a carotid endarterectomy. He was recently admitted to the hospital with respiratory failure that was attributed to heart failure. His medications include furosemide, lisinopril, carvedilol. His blood pressure is 152 over 98, and it's the same in both arms and his left leg. His exam's otherwise normal, and he has a normal chemistry panel. So you get a cardiac echo, and it shows a normal left ventricular ejection fraction. Where do you go from here?
This is a patient that I would be highly concerned for atherosclerotic disease. So renal artery stenosis would be certainly high on my differential for this patient. Furthermore, he had a normal echocardiogram, and he was admitted for flash pulmonary edema. This can also be an indication for revascularization or stenting. This patient's also on optimal medical therapy with the RAS blockade. So the next step, I would proceed with revascularization.
Well, thanks, Rima. We're going to finish up today's program with a couple of final key points about resistant hypertension. Chris?
I would say probably my takeaway point would be make sure you get a good history on the patient. By getting a good history, you can probably rule out a lot of things, including medication non-adherence, possibly pseudo-resistance, as well as secondary causes of hypertension, including obstructive sleep apnea.
And Rima.
It's important to understand the definition of resistant hypertension and to understand that it should be 3 agents at their optimal doses, one of which is a diuretic, before proceeding with secondary workup.
Well, Chris and Rima, thanks again for joining us today. And for all of you viewing, send us an email if you have any questions about today's program or questions about how to get ABIM maintenance certification points. And join us next week when my guest will be Dr. Deborah Gordish to update us on vitamin D deficiency. Until then, all of us here at OSU MedNet21 wish you good health.